Thank you for joining us tonight for Understanding Secondary Progressive MS. This webinar series is brought to you by Can Do Multiple Sclerosis and Novartis. My name is Laura Allen, Programs Manager for Can Do MS, and I will be your moderator this evening. Can Do MS delivers health and wellness education programs to help families with MS thrive. Please visit the Can Do MS website, cando-ms.org, to learn more about Can Do MS's online and nationwide in-person programs. Our speaker this evening is Randall Shapiro. Randy founded the first private practice comprehensive MS center in 1977, the Fairview MS Center, which was renamed the Shapiro Center for Multiple Sclerosis at the Minneapolis Clinic of Neurology in 2004. He was first elected president of the Consortium of MS Centers, an organization which he helped found. He has participated in the development of the Yucca Center, which is now called Can Do MS. He has been elected to the National MS Society Hall of Fame and has served on numerous advisory committees for them, including the Medical Advisory Board. He recently was presented with the prestigious Starfish Award by the National MS Society and the Lifetime Achievement Award by the Consortium of MS Centers. He also received a Lifetime Achievement Award by MSAA. He has lectured and written extensively on all topics associated with MS management nationally and internationally. He retired from private practice in 2009 to devote more time to teaching and consulting on topics related to MS. While he has participated in numerous research studies, he is best known for his educating and patient management style, often using humor to teach some sensitive topics. With that, I would like to turn the meeting over to Randy.
Well, thank you, Laura. I appreciate being here and talking with all of you out there. I'm talking to you from my home in Peoria, Arizona, which is a suburb of Phoenix. The outside temperature now is hovering around 100 degrees. I'm happy to be in the inside and air conditioning at this time and to talk to you about a topic that I have dealt with for all over 40 years and longer than that. My mother had multiple sclerosis, so I've been dealing with multiple sclerosis for more than I'd like to say. Needless to say, we have objectives for tonight, and the objectives are on your screen right now, and you can see them, but my objective is to teach you as much as I can about secondary progressive multiple sclerosis and multiple sclerosis in general, so that you'll understand the relationship between relapsing remitting MS and secondary progressive MS, that you'll understand the difference between secondary progressive MS and primary MS, and you'll become knowledgeable about the strategies for disease and symptom management in progressive and MS. And so let's see if I can get to the slides here. I'm going to try. There we go. I think I have it there. Go back like this. You know, it wasn't that long ago, actually, 4 or 5 years ago, that the National Multiple Sclerosis Society said that there were 450,000 people with MS in the United States, and we knew that number was really underestimated, but it was grossly underestimated. And the latest data that comes from the National MS Society tells us that there are over 1 million people in the United States with multiple sclerosis. You know, multiple sclerosis is a disease of the immune system. The immune system is the system in the body that fights foreign substances. So you know that the immune system in multiple sclerosis is overactive. So this is a disease of the immune system, which causes inflammation in the brain and spinal cord that's caused by the immune cells irritating and attacking structures in the brain and spinal cord. So it's a disease that inflames. And it seems that one of the targets that inflames is the myelin, the insulation of nerves that allows electricity to move very, very rapidly. So multiple sclerosis is a disease of the immune system that causes inflammation in the central nervous system, in the brain and spinal cord, that allows demyelination to occur. And when that demyelination occurs, the nerve itself, which is called the axon, is nude. It's lost its insulation. And then it can, in fact, break and degenerate. So multiple sclerosis is a disease of the immune system. Multiple sclerosis is a disease of myelin. Multiple sclerosis is a disease of axons. But more importantly, multiple sclerosis is a disease of people. And every single person who has multiple sclerosis is different. They are different. And so over the years, we have looked to see how we can account for this difference and be able to use the difference to describe the different kinds of multiple sclerosis. So we have had many different classifications of multiple sclerosis over the years. There's a clinical classification that I'm going to spend some time on and discuss with you because it's the most operational. But I'd like to point out to you that many of us over the years classified multiple sclerosis by where in the nervous system the disease was occurring. So we talked about cerebral multiple sclerosis, if the person had a major problem with cognitive problems. We talked about brainstem multiple sclerosis, if they had a lot of problems swallowing, double vision, and things of that nature. We talked about spinal cord multiple sclerosis, if the spinal cord was predominantly involved. And then we talked about the typical kind of multiple sclerosis, which is a little bit of this and a little bit of that. Back in the 1970s, we recognized things that we forget now because we have treatment for multiple sclerosis. But back in the 1970s, we could not treat the disease itself. And we recognized that a third of the people who had multiple sclerosis ended up in nursing homes. That's just a sad fact. Another third of the people in that era ended up in the population, in the general population of people that had significant disability. They weren't in nursing homes, but they were disabled. But there was another third of the people who had multiple sclerosis that did reasonably well, and we actually recognized that there were 20% or so of the people who had multiple sclerosis who, for whatever reason, got the diagnosis and then did really well. And we put a label on them that I didn't like, but it's a label that has stuck over the years, and we still don't like it. And we talked about those people having benign multiple sclerosis. The problem was that we couldn't predict who of the population of people with MS was going to be benign until we saw the fact 20 years later that they in fact didn't get worse. We had no treatments, so we couldn't say they didn't get worse because we were treating them. They simply did not get worse. Today's younger neurologists like to say that that benign form of MS didn't exist and doesn't exist, but I'm here to tell you it does exist, and it did exist, and I saw it over the years. I took care of many of these people over 20, 30 years, and I don't know why they didn't get worse. Maybe it was my wonderful personality, but I doubt it. I think that their immune system turned itself off and they did well. So in the 1970s, we talked about people having benign multiple sclerosis, and then we talked about some people whose multiple sclerosis was not so benign, but they really didn't get a whole lot worse, and they fluctuated with the course of the disease. They had attacks, which we called exacerbations or relapses, followed by periods of quiet, which we called remissions. And we talked about relapsing, remitting multiple sclerosis. And then we saw that the fact that there were people who had attacks, but they never quite got better. And so we talked about them having relapsing progressive multiple sclerosis. And it was a chronic disease, so we labeled them chronic relapsing progressive multiple sclerosis. They had attacks. With each attack, they seemed to get more disability and became disabled, but with attacks. And then there were some that just simply got worse and worse and worse without attacks, and we talked about chronic progressive multiple sclerosis. And you'll still see those names referred to sometimes by people who have been around for a period of time and by people who have studied the disease, that we have these chronic progressive multiple sclerosis. But the problem was these terms were not universally accepted. And when we really wanted to do research studies, because there were drugs to be researched now in between 1980 and the present, we clearly had to have a better classification that was more uniform and that people all over the world would recognize. And we knew that 80 to 85% of people with MS began their journey with fluctuations of their disease. They had the attacks, relapses, exacerbations, if you will, followed by periods of relative quiet remission. So we talked about that 80 to 85% having relapsing, remitting multiple sclerosis. And we knew over time that over half of those people would stop having those attacks and slowly get worse. So we talked about that being called secondary progressive multiple sclerosis. Secondary progressive multiple sclerosis. And we knew that 10% of people with MS just got worse from the get-go, and we called that primary progressive multiple sclerosis. Primary progressive multiple sclerosis. And 5% didn't read the book. and they started progressive and then began to relapse. So we call that progressive relapsing multiple sclerosis. So that's the classification that allowed us to do research studies. And so when the first research studies were done, they were done on the large number of people who had relapsing remitting multiple sclerosis. But most of us felt that these were all multiple sclerosis, that this was one disease with several different ways of looking at it. People are different. The disease showed itself differently. And when the first study was done, which was the beta-seron study that got approved by the FDA said this drug is approved for, and we thought they would say simply multiple sclerosis, but they didn't. They said this drug, beta-seron, is approved for relapsing remitting multiple sclerosis. And then in short order, we got Avonex, and we got Copaxone, and we got BIF, and each one of these was done on relapsing remitting populations, and the FDA said this drug is good for relapsing forms of multiple sclerosis. And it was the birth of like a new disease. So people say, what kind of MS do I have? Do I have relapsing remitting, or do I have secondary progressive, with that ominous word progressive? But they're really a disease that we're simply describing what's happening to the person. It's not like they are clearly different diseases. They are relatives, they are similar, they're the same background, they're the same demyelination, they're the same inflammation, but things change over time. The disease changes over time. So we change the name of the disease over time. So some may start out relapsing remitting, and then if untreated, over half of them become secondary progressive. And so we understand that issue that occurs, that these, and so this was the classification, the clinical classification that we get the studies on, the major studies for all the new drugs that you've seen, all 18 new drugs that you've seen over the years. But we can classify MS in another way too. We can classify MS by what it looks like underneath the microscope, and the Mayo Clinic did that. And they talked about type 1, type 2, type 3, type 4 MS. And so there are many different ways to classify. This is the clinical classification for multiple sclerosis. So here you see on your screen the relapsing remitting on the top two lines there, the fluctuations with relative stability in between. Secondary progressive, you see the line begins to creep up between attacks. Primary progressive, the line goes straight, and progressive relapsing. So 80 to 85% relapsing remitting, over half of them along the way become secondary progressive, 10% are primary progressive, and 5% progressive relapsing. Well, MS has changed. The disease actually has changed because we started treating MS in the 1990s, and we actually have changed the way it looks. So we still see people who present themselves with relapsing remitting disease. But we've noticed that if we treat and we can slow the disease down, we do slow the disease down. And we see people who have switched into the secondary progressive phase, but they may not be progressing. That sounds crazy. They're called secondary progressive because they did progress and then they stabilized and stopped progressing. I used to see those in my office all the time. And so I make the point, and I'm going to make it again and again, that every single person with progressive MS, well, maybe not every single person, but almost every single person with progressive MS will stop progressing at some point in time, because you don't usually die from MS, you die with MS. But our goal is to stop the progression before disability gets to be severe. So we have relapsing remitting that can change to secondary progressive, and then it can stay active with attacks and still be secondary progressive. So it can be active and progress, and we can see that activity on the MRI scan, which we'll talk about in some detail in a few minutes. But we can see the activity by looking at how the person's walking and talking and functioning as well. So we look for relapses and activity on the MRI scan, and then we look for our neurologic examination to see how people are walking and talking and functioning. So we talk about secondary progress that's active and has progression, secondary MS that's active on the MRI scan with relapses, but the person isn't really getting worse. The person who's secondary progressive MS was labeled secondary progressive MS, but we're not seeing activity in terms of relapses or MRI activity, but their disease is getting worse in front of our eyes. And then we see people with secondary progressive MS who have quieted down. The MRIs are not active, they're not having any relapses, and they're not progressing. So it became important for us when we look at people to put in studies that we have people who are active and progressing, not active without progression. So it's important that we classify these people this way. And then we looked at primary progressive in just exactly the same way. So I needn't go through all of that in detail like that, except to say that we got rid of the progressive relapsing category and lumped it back into the primary progressive category. So now in the present, we have 3 categories of MS. We talk about relapsing remitting MS, which is the largest category. We talk about secondary progressive MS that's active with progression or active without progression or not active, but with progression or not active and without progression. And then primary progressive MS, which is the one that gets worse from the get-go, but can still have a relapse here and there, either active by MRI or not MRI with progression or not progression. This is an old chart just giving you the numbers from the old classification and the percentages that you see there, just to see it visually, if you will. So let's spend just a moment and talk about relapsing remitting MS, the single largest group of people with MS. 80 to 85% of people begin with this category, if you will, and you have clearly defined relapses, and everybody is always asking me, well, Randy, what's a relapse? So a relapse is a new neurological symptom that occurs that lasts 24 hours or longer. And I like it to be accompanied by something I can see. So that means that to me, every relapse isn't the same as every other relapse. Numbness, tingling, blurred vision, dizziness don't mean the same to me as weakness and clumsiness. And there are doctors who think that I'm all wrong in that. That's all right. So a relapse is a new neurological symptom. It may be an old one that's gotten significantly worse, but normally it's a new neurologic symptom that lasts 24 hours or longer. Now, there should be no other reason for that. You know, when you get a fever or you get stressed or you get fatigue, you get symptoms that come out all over the place. And that can be what we call a pseudo relapse. So we're looking for there to be no fever. We're looking for stress and fatigue to be taken out of the picture as much as we can. Sometimes we can't take it all out as much as we can. And then we would like there to be full recovery after that relapse, but maybe not. Maybe there won't be full recovery, and then we begin to see an accumulation of disability. So a relapse is a new neurologic symptom lasting 24 hours or longer. I like it to be accompanied by a finding on examination. So Jen, then what is progressive MS? And that word progressive, whether it's with secondary progressive or primary progressive, has an ominous connotation to it. But as I said, everybody with progressive MS, or almost everybody, will stop progressing at some point or another. Is it pathologically different when we look at it underneath the microscope from relapsing MS? Well, the answer to that is yes and no. If I gave slides to people who are good pathologists and didn't tell them this is relapsing remitting or progressive MS, they couldn't tell me from the slide what it is. They look alike under the slide. But relapsing MS, as I told you a little bit earlier, has a lot of inflammation associated with it. Irritation, if you will. When that immune system is attacking the nervous system, it causes an irritation, like if you bumped yourself and you got a bruise and it started to swell. The swelling is called edema, and that actually occurs in the nervous system as well. So we see in relapsing MS more inflammation. And then when the scarring occurs, the sclerosis occurs, after the attack is settled down, a different cell goes and comes in to heal it, but it doesn't heal it well. It doesn't replace the myelin, it scars it down, and we call that sclerosis or scars. Then we see scarring. So we see more scarring and more of those axons degenerating, if you will. So we see degeneration and scarring in the secondary progressive form of multiple sclerosis, which is somewhat different. Now, as I said to you, we like it to stop progressing sooner rather than later. And often when people get into their 60s and older, the immune system poops out a little bit, and we don't see these attacks and see the progression in the same severity, but you can never tell because every single person is different. And we don't have a meter to measure that very well. We may wonder, is there a sexual predominance between these MSs? And the answer is that there is a sexual predominance in relapsing MS. There are more women than men that get this disease by almost 4 to 1. And so that means that in secondary progressive MS, we're going to see more women than men by almost 4 to 1. But interestingly enough, in primary progressive MS, we see a 1-to-1 ratio of women to men. So when the disease starts out progressive, and it just goes without relapses, and we can call it primary progressive MS, that's a 1-to-1 male to female ratio, and there doesn't appear to be that sexual predominance. Men often have a harder time with MS than women, and African Americans can have a harder time than Caucasians, and that has something to do with the genetics of multiple sclerosis. So there is some differences that we see in some people. Now, secondary progressive MS, as I have hammered home, begins as relapsing remitting MS and then develops a gradual worsening, independent of relapses or aging or other conditions that occurs over a period of time. There may be attacks. What's important is that the disease is progressing in terms of disability without stabilization. This is the major disabling subtype of multiple sclerosis. It is the most severe clinical and has the most problems with social and economic impact. And if untreated, relapsing remitting, we see that over 50% of people will get into this transition stage of secondary progressive by 25 years. It's an expensive disease. This is 1994 economic dollars. I happen to have the slide, so I put it up. Back then, the national annual cost was 11.9 billion. This is next slide here is in 2007 international dollars. If you look at the bottom of the slide, in the United States, it was $50,707. So it's an expensive disease, and it's gotten more and more expensive with the drugs that add to the cost, but hopefully will keep the disability down so we have less indirect expenses. As I mentioned to you, in secondary progressive MS, we do see abnormalities on the MRI with our new lesions that are active, and we determine they're active because they enhance when we give them a substance that allows us to tell the new lesions from the old lesions, the gadolinium. And they'll enhance for a period of 6 weeks or so. We see these new lesions, that these new lesions are more likely to form scars than they do if they're in the relapsing remitting phase. Sometimes we see lesions in the relapsing remitting phase that go away. In the secondary progressive MS phase, these new lesions form fixed plaques or scars. So there appears to be a decreased recovery mechanism within the nervous system. It can't heal itself as well. And then we start seeing the volume of these lesions, of these scars, if you will, getting bigger. We call it volume of scars lesion burden or burden of disease. And we see the burden of disease getting bigger even without the enhancing lesions being counted. We think this is occurring because we're losing our nerves, the axons, and the brain is shrinking. So we see new enhancing lesion rate higher in secondary progressive MS who have relapses. So if a secondary progressive person has relapses, we see these enhancing lesions more often than if they don't have relapses, because that's the inflammation process that we have seen previously in the relapsing remitting disease. So this is a very old slide, but I wanted to show you how we used to determine the burden of disease, the volume of lesion abnormalities in a person with multiple sclerosis. So here you see a big lesion and you see it outlined in white. And we did that manually. That's how we did it. And then we looked at the average, the area of that, and determined the lesion abnormalities, the volume of lesion abnormalities. Today, the computer does that. The computer does that. But within that lesion, you see axons, and this is a common slide that everybody has seen from Bruce Trapp. And if you look, the red, that's over the yellow, so you see the yellow line, and then it's covered by red. That's a happy myelinated nerve. I'm going to try to see if I can do this and see if this will work. If I take my laser pointer here and move it over here, you see the red and you see the yellow. That's the axon, a happy axon, because it's myelinated. And then you see how it's been demyelinated here. It's lost its red myelin, if you will. And then over a period of time, this breaks. And when it breaks, it balls up. And when that occurs, that's not a good sign, because that nerve will never come back. It's gone. It won't work, and it will never come back. So that's not a good thing. That's what we're trying to prevent. And then it will scar and it will degenerate. So how do we diagnose secondary progressive multiple sclerosis? Well, first, let's take a step back. How do we diagnose relapsing remitting multiple sclerosis? It starts by history. We're looking for somebody with relapsing remitting MS who's between the ages of 15 and 55, who have had relapses and remissions, fluctuations of their neurologic symptomatology, and who have multiple abnormalities on their neurologic examination, more than one abnormality in their neurologic examination. Those are the three cardinal criteria, if you will, to diagnosing multiple sclerosis. We like them to not have any other disease that can mimic MS, so we look for that. But we look for those three clinical criteria: the age, fluctuations, and multiple abnormalities on their neurologic examination. And then, of course, we're likely to do an MRI scan and look to see if we can see those abnormalities. Most of the time we can, and then we feel very secure. Occasionally we can't, and we feel less secure. So we can look at the spinal fluid, and we can look for abnormalities of the immune system in the spinal fluid, and that can help us. We can look at the eye with tests of eye test, optical kinetic tests, or visually evoked responses. So that's how we diagnose relapsing remitting multiple sclerosis. As this transitions to secondary progressive MS, the diagnosis is by history. There's no specific neurologic finding that tells us, well, this is now secondary progressive MS. There's no laboratory finding that tells us this is secondary progressive MS. There's no specific MRI marker that tells us that this is secondary progressive MS. So the diagnosis is me. I'm making it to you. And so you can feel less secure about that, because we all like tests to tell us that that's the diagnosis. But that's why you may hear from somebody, well, you have relapsing remitting MS, and somebody else may say, well, you have secondary progressive MS, because they look at it somewhat differently. The diagnosis is made by history, not by the findings, not by the laboratory, not by the MRI. Primary progressive MS just gets worse from the onset, as we talked about before. So how do we monitor this nebulous thing that we're calling secondary progressive MS? Well, we do that by looking at you. We have to do a neurologic examination. That's how we tell that things are getting worse. And we have to put numbers on that examination so we can actually see that things are getting worse. Because if I simply ask you, are you getting worse? You may be having a bad day with your mother-in-law, or you may be having a bad day with the kids, and think that things are getting worse. So I have to have objective data. A clinical neurologic examination should be done on your appointment, after appointment, with that being marked very specifically as what your reflexes look like, what your strength looks like, how well do you walk, how fast do you walk, how do you think, etc. So the clinical examination is very important, and we put a score on that. And that score is called a disability status score. The disability status score was invented by a neurologist by the name of John Kurtzky, who was a friend of mine who passed away a few years ago. And John was a very brilliant, kind physician who looked at large numbers of people and came up with a plan to be able to score them for disability. And then it became expanded to be called the Expanded Disability Status Score, or EDSS. Some of us old folks call it the Kurtzky score still, but it's EDSS, Expanded Disability Status Scale. This scale goes from 0, which you see at the bottom, to 10. Well, obviously, I told you already that you rarely die from MS, you die with MS, so we don't see a lot of 10s until people die of heart disease and cancer and strokes like everybody else. But you don't go to this disability, as you see, from no disability to completely dependent in a linear straight line fashion. It just doesn't work that way. So when we measure people's disability, we understand that you can go from 0 to 3. 0 to 3. And at 3, you're walking pretty well. As you see there, they have full ambulation. May not be perfect, but it's full ambulation. You look pretty normal. But you may be wetting your pants, you may be overly fatigued, you may not feel entirely well, but you look pretty good. And so people get tired of hearing, oh, you look so good, but you may look pretty good. But as you go from 5 to 6, you go from being able to walk without an assistive device to requiring assisted device to walk. And as you go from 6 to 7, you go from being able to walk with an assisted device to not being able to walk at all. So it's not a linear scoring system. And the neurologist who does the Kurtzke EDSS has to know how to do it in order to put the numbers properly. If you do it properly, you'll find some interesting things. You'll find that people will cluster in a large multiple sclerosis clinic such as mine. People will cluster around an EDSS score of 3 and around an EDSS score of 7.5 to 8. They cluster in those two spots with a ski slope in between. So there's, let me see if I can do this again here with the marker. We'll go up to the laser pointer and we'll see what happens here. If I can get my laser pointer, I'll try it again. So I can see what happens here. We'll go to the laser pointer and now they cluster here at 3 and they cluster here at 8. So you get a big bump here and then it comes down and then you get a big bump here. And so we worry about people who are in this part here that they may be going down fast here and then they stabilize here. We don't want that. We want them to stay here. And that's why we believe in early treatment. So that's my pitch, that early treatment is really important because we don't want people to shift down into this hill and come back up there. Okay, so that's the Kurtzke EDSS score. We monitor with that Kurtzke EDSS score. And then, of course, we monitor with the MRI. We watch this MRI. And let me see how good we have it here. And we do this MRI in different ways. We may do it with no enhancement. That is, we just put you in the scanner and we do the scan in a T2 weighted fashion, we call it. And we see the spinal fluid is white. And we see spots as white as well. And that makes them hard to pick out. There's a spot, for example, here, but it's hard to pick out because the spinal fluid is white. So you can flip a switch, and that turns the spinal fluid dark, and we call that a flare scan, and then the white spots stand out. These are the areas of inflammation and scarring. We cannot age these. We don't know how long they've been there. And so you see the flare scan there, and you see the flare scan here. You see the spots. Then we may give this magnetic substance, which will go through to the acute new spots, goes through what we call the blood-brain barrier, and it will enhance the new spots for 6 weeks. So you see this spot here. That's a new spot that's there for 6 weeks. You see that spot here. We can't age it on that scan, but we can age this as a new spot because we gave the gadolinium. Now, the gadolinium has some issues these days. It may hang around, so we don't want to use that casually, but it gives us a lot of information. So we do the scans, and we may do the scans of the spinal cord as well. Here is a gadolinium enhanced scan with lots of enhanced abnormalities that are all new. This person's having very active disease, if you will. And then when those active spots degenerate and the axons break down, we get what we call a black hole. And you see these holes, they look like Swiss cheese in the brain here. And that we don't like to see black holes because we know that that's damage that can't be brought back by the techniques that we have available today. So we were trying to prevent black holes. We're black hole preventers, if you will, by doing everything we can to prevent black holes from occurring. So that's what occurs in more progressive MS, and we see less of the inflammation and more of the black holes. And when those black holes occur, it takes up brain, and the brain shrinks. And we call that shrinkage atrophy. And we can measure the atrophy. The atrophy occurs because we've lost the axons, and the axons are the nerves, and the brain then shrinks. And so I wanted to show you a picture of atrophy. This is the brain that doesn't have a lot of atrophy. The spinal fluid is the black here. You see how nice and plump the brain substance is. Now this person, which is a different person from the first person, has more atrophy. You see the more spinal fluid has taken its place. It shrinks. The brain has shrunk. And then this one has much more shrinkage. And that's called significant atrophy. And so we measure atrophy. So we follow people by measuring atrophy as well with with the MRI. Here's another picture of atrophy of what we call the corpus callosum, which connects the two sides of the brain. See how nice and fat this is a normal type of corpus callosum, how it should be. And you see how thin it's gotten in this picture. That's because of the atrophy that has occurred due to multiple sclerosis. So we monitor the disease by looking at the neurologic examination. We monitor the disease by looking at the MRI. And we monitor by doing some tests how the body is functioning. We look at cognitive testing. We call that neuropsychological testing. It's more difficult because it's more subtle to some degree. It takes longer to do. We can look at upper extremity coordination and strength with the 9-hole peg test. We can do a 25-foot timed walk. And we'll do these when we're monitoring for progressive multiple sclerosis. So we know how to now monitor the disease. Now, how do we actually manage the disease? Well, I'd like to tell you that we give this magic drug, and everything just goes away and gets better, like we do with bladder infections. We give an antibiotic, and usually the bladder infection gets better, and everybody gets better, and everybody's fine. It's not so simple. Not so simple. We thus far don't have a way to put myelin back into the nervous system. There are a lot of studies going on looking at remyelination. I'm not too impressed with any of them, even though there are a lot of doctors who get very impressed with their particular research. There's a lot of studies going on and figuring out how to protect the myelin from how to allow the nervous system to repair itself. But we're not good nervous system repairers. Maybe stem cells someday will put myelin back into the nervous system, but not the ones that you read about in the newspapers so much. So now we have to work at prevention. That's what our whole purpose is these days in managing progressive MS, is to try to prevent the progression. Now, I told you that when we have secondary progressive MS, we often will see relapses, or we'll often see activity on the MRI scan because there's inflammation going on. And so that inflammation is occurring because of the activity of the immune system attacking the nervous system. So one of our goals is immune system management. We go after that immune system to try to manage that. Now, that's not a new concept. Beta seron, when it first came out in 1994, was called beta furon everywhere else in the world except in the United States. So in Europe, it was called beta furon. It's beta 1b. And the beta seron studies were done on relapsing multiple sclerosis, and they showed a decrease in the relapses and a decrease in the activity on the MRI. So the Europeans said, well, let's look at beta furon in secondary progressive MS. So they took secondary progressive MS, 750 patients, and they randomized them. Half of them got beta furon, half of them got placebo. And after 2 years, they had 90% of the data. And my goodness, it worked. Disease slowed. The patients had less new lesions. Their whole volume of disease lessened. It took longer for them to get to a wheelchair with the progression. They had fewer attacks. And we thought, my gosh, we have a drug for secondary progressive MS. But we in the United States decided we would repeat the study. So we did the North American beta interferon study. It was a beta seron study with 900 patients. A really good study. Half received beta seron, half placebo. 2 years, it was stopped after 18 months because it just didn't work. The disease was not slowed. The beta seron patients had fewer new lesions, but their burden of disease lessened, and they had fewer attacks, but the disease was not slowed. So the drug was not approved for that secondary progressive form of multiple sclerosis. Now, why would that happen? Well, part of the reason is the way you select your study patients. And so selecting study patients in these studies is so crucial if you're trying to show a change. In Europe, the patients were younger. Their disease was younger. They were more active in the relapsing phase of their secondary progressive disease. We had another drug we were testing in America at the time. It was called lutamide. It didn't reach the FDA, but it was an oral drug. And so a lot of the patients were siphoned off into that study. And so we never got that treatment. In Europe, they could use it for secondary progressive MS. But a cancer drug that was used for the treatment of cancer, mitoxantrone, was studied. Nofantrin, and that slowed clearly secondary progressive multiple sclerosis, but it had terrible side effects. People got heart disease. People got leukemia. So while it was approved, and it was approved, it was used for a while. I used it for a while. It never took hold because of the side effects. So each of the older drugs had studies in progressive MS. We talked about the beta-seron, beta-furan study. The Rebif trial the drug Rebif had a trial in secondary progressive MS. It was called the Spectrums trial. Paxone, clotrimazole acetate, had a trial in primary progressive MS. It just did not work well enough to be approved. But now we move forward and we got newer medicines that are more potent, if you will. And we've got a different population of patients that we're treating because we've treated people early. And so we're getting people earlier as they're getting earlier in their phase of progression with the disease. And so we have drugs like ocrelizumab that were tested in relapsing MS and also in primary progressive MS with fancy names to the studies like OPERA-1 or OPERA-2 or Oratorio. Yeah, they're just fancy names to the studies, but suffice to say, in the primary progressive study with ocrelizumab, they could show a statistical difference because of the anti-inflammatory effect of this B-cell medication. And so it became approved. Cladribine, Mavenclad, Siponimod, Mayzent, the newer drugs that were just approved were also approved for relapsing forms of multiple sclerosis, so secondary progressive MS with relapses, particularly Siponimod in the Mayzent study was approved for secondary progressive multiple sclerosis with relapses. So we have drugs now if the disease is showing activity, not just progression. Progression doesn't cut it. It has to have activity with some relapses and with some MRI abnormalities that are new to help us. We also treat with methylprednisolone for these attacks. They're not good for the long-term course. IV cyclophosphamide, my goodness, we used to use that. Hard drug to use. Hard drug to use, but it did slow multiple sclerosis down when it had activity. IV cladribine, I used to use as well. Now it's oral cladribine that's approved, but I use the IV cladribine. It slowed MS down. Nobody does that anymore. Methotrexate, occasionally you'll see plasma exchange. High-dose biotin and simvastatin probably don't work so well in this form of the disease. Need far more study before anybody really thinks about that. But stem cell rescue has potential. It's maybe not ready quite for prime time, but the idea being that you would eliminate that immune system that you have, restore it with stem cells from the bone marrow that have been cleaned up and reset the immune system again. So we manage the immune system when we're managing the disease itself. Still, we have mitoxantrone. People don't use it so much, but it actually does work. It's a risk-benefit ratio that you have to worry about in looking at this particular medicine because it can cause heart disease significantly and cause leukemia as well. So we'd like to be able to manage the disease better, but we can manage the symptoms of progressive multiple sclerosis. And we manage them more aggressively than we do typically with the relapsing forms of multiple sclerosis. So one of my patients threw this for me, and I hope that we can use some humor through this mechanism of a webcast here. I can't hear you laughing, and so I can't get any feedback, but this is what spasticity looks like to a young neurologist I can tell you, you only do that once if you're a male, or if you're a female, doesn't matter. You'd only do that once if you're a neurologist, to stand in that position. But that's that stiffness, that hyperactivity, the hyperactive reflexes, the restless legs, the stiffness, which is velocity dependent. The faster you move that leg, the stiffer it gets. The faster you move it, the stiffer it gets. That's real spasticity. Now, exercise is important in treating spasticity. So we like all of our patients who have spasticity to be in an exercise program, taught by somebody who knows how to teach stretching in an appropriate manner, to get the stretching of these very stiff muscles that are stiff because of a lack of regulation in the nervous system. We have a lot of oral drugs that we can use, but when we have significant progression of the spasticity, as we sometimes do in significant progressive MS, we may have to put a pump into the nervous system to put this baclofen, this anti-spasticity medicine, right into the spinal canal. And so I did the research in this in the 1980s that got it approved by the FDA, and it's still being utilized. That catheter goes into the spinal canal. The pump looks like a hockey puck. They've modernized this. Is an old picture. It's more modern today, but it's still the same principle. We can change the dose, and it's very small doses give you a very big effect. And I wanted to show you a picture of Mark. And Mark here has a smile on his face. I don't know quite why Mark has a smile on his face, because Mark has a problem. This leg is stiff as a board. It won't move. This leg is also stiff as a board. It won't move either. And you can see that if I try to wheel Mark forward, his heel is going to get caught. I have to tip him backwards. He has a smile, but he has no reason to smile. He's got a problem. But we put a baclofen pump in Mark, and he still has a smile on his face. But now I want you to note that his legs are bent, his feet are on foot pedals, and Mark has power. Mark has power. The answer to disability is mobility. Any of you who know me know that's my mantra. The answer to disability is mobility. We have to stay mobile. And so with secondary progressive MS, primary progressive MS, relapsing remitting MS, the answer to disability is mobility. But when you have MS, I don't care what kind, you're looking for a sign on the freeway that looks like this, because the bladder is a real major issue. A real major issue. And if you have progressive MS and your mobility is impaired, it's particularly an issue. So when we have bladder problems, we check for infection. And we often will see infection, particularly as the MS is more progressive, and we need to treat that infection. Now this slide says upper tract disease is rare. By that I mean kidney disease is rare in multiple sclerosis. It seems like it should be common. If your bladder has infection, why don't your kidneys get infection? And occasionally they do. We call that a pyelonephritis, but it's rare. It doesn't happen as commonly as you might think. And so we check for infection and get that treated. And then we see how much urine is left in the bladder. And with secondary progressive MS, we often find a lot of urine left in the bladder. And when there's a lot of urine left in the bladder, we check it with an ultrasound, or we can cath you, put a tube in for residual urine. Then we have to be more aggressive with how we manage that, because we can't, no drug works well to eliminate the urine. And so we may want to teach you how to remove the urine mechanically with a tube that you will put into your urethra opening. If you're a male, it's through the penis. If you're a female, it's underneath through the urethra. And that depends on some hand coordination and some sensory feeling. And so we have to keep perspective on that. It's not just good enough to say, well, you're self-cath. We need to be able to see whether it's rational and reasonable. And if it's nothing is working, we'll actually have testing done to see why nothing is working. We call that urodynamic testing. We may do that before I talk about sitting. I'd like to just mention something about catheters. I'm going to come back to this in a moment, but well, maybe I'll come back to it when we we'll talk about when we get to it. I know that you know that women tend to sit to pee, and I know that you know that men stand to pee. But if you have progressive MS and you have mobility problems, you need to sit to pee. And you know, I recognize that that can be difficult for men to get a hold of, because that's not what they've been raised with. They've been raised with standing to pee. And so I thought I'd show you a picture of my bathroom at home. I can hear my wife right now screaming, "Randy, you left the toilet seat open. You know better than that. I sat in the toilet." She wants the toilet seat to be down. Well, I understand. I'm pretty good at that. I sometimes slip up. But you know, my wife is an interior designer, and so she redesigned our bathroom. So this is our new bathroom. That's the way it is at my house. I have to learn to sit to pee pretty well. And it's hard for me to learn to sit to pee. I keep working on it. I'm working on it, but she says I splash all over, and that's a problem. So I'm making a little light of this because it's a hard topic to sometimes talk about, but it's an important topic to understand. And so we have the medications. They don't work as well as we'd like. For the male, we can put a condom catheter on. Condom is what you think it is, and it's attached to a tube, to a bag, so you don't have to, you can just pee and it'll just go in if your bladder will work. But if your bladder won't work, and the answer to disability is mobility, and you're not going anywhere because that bladder is the problem. You have to get to it all the time. You can't transfer it, can't go to a restaurant there. It's not very disability friendly. Sometimes we'll put in a Foley catheter. Now, we don't like doing that because we know there'll be infections and things. And we'll move the catheter to above and put it in from the skin above. We call that a suprapubic catheter. But it can make life so much better if, in fact, you have problems with transferring and going to the bathroom. So I don't like to talk about my mother too much, but I will. My mother had multiple sclerosis. I was raised with the disease. Obviously, my mother died many, many years ago. She was a wonderful person. She had significant disability in my later life with her, and we stopped going to restaurants and stopped going to anywhere where we had to find bathrooms, and I had to go into the women's bathroom to take her in to help her, and it was very difficult. And then we put a Foley catheter in, and all of a sudden her life got better, magically better overnight. She could go anywhere. She could go to a ball game. She could go wherever, to a movie, because she didn't have to worry. The catheter drained to a bag, and we emptied the bag. And sometimes when if that gets irritated and doesn't do well, we ask the surgeon to take a piece of intestine and to expand the bladder, and then we have a diversion, which is a real surgery, but can also be important for significant issues. The bowel can be a problem, so a bowel program is important. It's important to have enough fluid and to be on a high-fiber diet and to take bulk formers and to take and have your bowel move at a particular time of day right after a meal, because there's a reflex at that time. So we teach the use of suppositories and mini enemas and occasionally enemas, but we don't like enemas because they will disturb the bowel long term. But we have to control the bowel in order to make it work well for people, because the answer to disability is mobility. So we have to keep people mobile. So we get them on a diet, and we get a stool sample. Well, maybe not that kind of stool sample. And then we get fiber, but maybe not that much fiber. And we know that heat makes the symptoms of MS worse. And we know that cooling can make them better. So on a hot day here in the Phoenix area, cooling vest. But when I practiced in Minnesota, I retired here to Phoenix. We use cooling vests in the summer, and they're very important because heat makes the symptoms of MS worse. Cooling will make it better. When we have progressive MS, I like to spend a little bit of time talking about the skin. You know, the skin is an important part of our immune system. You should understand that. But it also prevents the foreign outside environment from getting in, which is so important to keep the bad stuff out. And if you're not paying attention to the skin and monitoring it and looking at it, the skin can break down. We have a term for it in medicine called a decubitus ulcer, or bed sore, if you will. And that decubitus ulcer can get infected. And we need to treat that very aggressively. We need to prevent that breakdown by teaching transferring techniques and monitoring the skin very carefully. Because if it gets infected, if you get a decubitus, you can die from the infection that occurs. So I say the skin kills. The skin doesn't kill. The infection itself that is created by the skin breakdown kills. So it's preventable, absolutely preventable, but we have to monitor it and watch it. So the answer to disability is mobility, which means you get the proper tools. If you need a cane, you use the cane because you have to stay mobile. You need to know what hand the cane belongs. You need to know how to use bilateral assisted devices. If we need a walker, we get a walker. If you need a brace, there are all kinds of fancy braces these days. If you need a seating system, you need to get the proper seating system. These three-wheelers are great if you can walk, but if you can't walk, they're not good enough. You need to have a formulated wheelchair which will prevent the skin from breaking down. It needs to be made for you. And you need to have restorative rehabilitation work at making you better, if you will. And we work at the spasticity. We'll work at the coordination. It's very physical. It's very specific. We can measure our success. We can measure how much time it takes and whether we're going to make it or not. But if you have a progressive disease, maintaining function despite progression becomes important. Maintaining function despite progression becomes important. And that's called maintenance rehabilitation. That's preventative. That's non-specific. It's long-term. It's more general. There's a spiritual aspect to it. So if you can't eat with the normal tools, we get you different tools so you can eat. We maintain function despite progression. The answer to disability is mobility. And so when we have to look at the person who has MS, and we have to also look at the caregiver. How are they? Are they going to burn out? What's the living situation going to be? And so if MS gets terribly progressive, we have to pay attention to lots of other things. And so we created, over about 40 years ago now, a program for progressive MS. We called it the Achievement Center, and it was at Fairview. So it's the Fairview Multiple Sclerosis Achievement Center, which is a hospital in Minneapolis. It's maintenance rehabilitation. We did that, and it was the first of its kind in the country, and now it's been copied, and we're so proud that it's been copied in many places such as Sacramento and Kansas City and Rochester, New York, and many other places around the country. Some of them call it achievement centers. For maintenance rehabilitation, where people with progressive MS can go for maintenance rehabilitation, where they can not just simply fill their time. It's not a babysitting service. The goal is to improve their lives by stimulating them to grow. And the growth can be physical, mental, and spiritual. And it will lead to independence, and it will lead to survival. And we did studies that actually showed that. We did those studies. We've had these programs now for many, many years. We had over 200 people when I was in Minneapolis. I don't know what's going on there now because I've been gone. But we prevented the secondary complications of MS. We kept people out of nursing homes. We kept people out of hospitals. And we delayed the functional progression of disease by keeping people functional and in society. These are not the young growing old. Yeah, I'm sorry. These are the young growing old, not the old getting older. So the programs that are done at these centers have to fit the age of the individuals. They must emphasize the therapeutic benefits. People have to buy into them, and they must be paid for, and that's a problem. So grants are important, and getting Medicaid to pay for it and getting insurance to pay for it is important. And the spirit is involved in all of these programs. They have a purpose. The purpose is maintaining one's function and keeping them in society, and preventing secondary complications is cost effective. So everyone gains from these kinds of programs. But it takes a village. It takes a village to do this. And so we have to sometimes recognize that we lose that battle. And then we have to look at long-term care with progressive MS. Residential nursing home units for younger people, mind you, for younger people have to be somewhat different than they are for older people. They need more bathing. They need more bathing, and is actually cared for under Medicare regulations. Younger people sweat more. They have more stress. More bathing has to occur. They have to have television, cable television, because they have to fill their time. That's expensive. We know that. Catheters become an issue, and they have to be dealt with appropriately. And In some cases, smoking is an issue in these residential nursing homes. But clearly, in a younger population, we have issues with drugs, drug abuse, and sexual activity and sexual advances that occur because of youth and cognitive problems, and they have to be understood and dealt with. Now, in this era, and I've lived through it all now, I guess, for the first time in history, we can potentially possibly alter the course of most types of MS with the medications that we have available. We can improve the quality of life with the rehab and the symptomatic drugs that we have available and treating the person that we have available. So we can, for the first time in history, potentially possibly alter the course of most types of MS and improve the quality of lives of those with the disease process. And I'm aware of the fact that I use the word potentially and possible because it doesn't always work. We do our best, but we try to make the best with what we have. And this course is done through Can Do MS, which used to be called the Jimmy Huga Center. Jimmy Huga was a skier who passed away a number of years ago, but I knew him well. And suffice to say, Jimmy had the can-do attitude, and that's that attitude that we have to have with this kind of disease process. And Jimmy always made the best with what he had, even though he wasn't dealt the best hand of cards. He made the best, and so we want the Jimmy Huga can-do attitude. And now, Laura, I am going to turn this back to you and open this up for any questions that I might hopefully answer. We'll see if I can answer them. We'll give it a whirl.
Thanks, Randy. That was awesome. We got a ton of questions and a ton of great comments about your presentation and just how informational it was. So thank you for that. I'm going to start with a somewhat specific question. Do you recommend Botox for neurogenic bladder?
Well, it all depends. That's a good question, and especially for the more progressive form of multiple sclerosis. Botox is a medication that can paralyze, if you will, the muscles of the bladder. And when we have a hyperactive bladder, a bladder that's small and hyperactive that won't respond to the routine medications, and most of them, by the way, do respond to the routine medications that we use for them, sometimes the urologist can put Botox into the bladder and slow it down. Now, having said that, the typical bladder in progressive multiple sclerosis is not that kind of bladder. It's a bigger, thinner bladder. And we wouldn't want to be putting Botox into that because it's already paralyzed too much. We're trying to get more tone to it rather than less tone.
Okay. What range should the 25-foot walk be in?
Well, it's really a comparative range. Everybody has their own 25-foot walk. Usually people can walk it in 12 to 15, 16 seconds. It's typical if they take off and walk normally with it. But that's not what's important. What's important is how did you walk compared to the last time you walked? And so when I do the 25-foot timed walk, I time it for the 25 feet, but I also count the number of steps that it takes you to walk the 25-foot timed walk. So I get two numbers. I might get a number like 12 steps or 6 steps, 12 seconds, 10 steps, 14 seconds. And then I can compare it from visit to visit. And it's like a fingerprint. When things are going well, that 25-foot time walk will be pretty stable from person to the same person from visit to visit. It may be different from different people, just like our track stars that can run fast and then I can't run fast. But their time 25-foot walk seems to maintain from visit to visit. But if I see a change from visit to visit, that tells me that the disease is progressing or something is wrong. There's an infection. Something is wrong.
Okay. Can anything be done to help the cognitive impacts of MS? Despite being a full-time wheelchair user, this participant says that the cognitive impacts are his worst MS symptom.
Yes. The answer to disability is mobility. Let me tell you a story. I like telling stories. So when we started this achievement center, it was a new concept. Nobody knew quite what we were doing. I needed to have some patients to go to the achievement center. We had staff, a PT and an OT and a speech pathologist and a full-time chaplain and a social worker, and they're all waiting to help people, but we needed some patients to go. So I looked at my patients who were in wheelchairs with progression of the disease. And I said, you should go to the achievement center. And they said to me, hell no, I'm not going to any achievement center. I'm not going to go out there. And because people who have more progressive MS tend to withdraw from society. They tend to stop doing things. They're more happy in their home, but they become vegetative. And so I said, you've got to go to the Achievement Center. And through my personal will and because I had good patients, I got them to go to the Achievement Center, and their spouses and significant others and caregivers came back to me after they came back for return for 4 months and 6 months and said, my loved one, they got smarter at the Achievement Center. They got smarter. And I said, well, gee, that doesn't make sense. We're not giving B12 shots at the Achievement. I don't know, why would somebody get smarter? There's no known age at the Achievement Center. They don't know what was going on there. And so then I looked at it and I thought about it and I came to the realization that yes, they were getting smarter because they were going to the Achievement Center and their brain was being stimulated. People were asking them, how are you feeling today? What do you think about the weather? What do you think about the president? What do you think about the Twins? What do you think about the Vikings? And they responded and they started talking to each other and they had groups and they started using their brain. And as Fonda is saying, the brain is not a muscle, but if you don't use it, you will lose it. And so these people got smarter because the answer to disability is mobility. So, and I don't have a way to put cognition back in your brain except to use the brain. That means doing exercises, brain exercises. That means going to church, not for the religion part, for the social part. That means you can go for the religion part too, but go for the social part. Go out to eat, go to movies. Don't withdraw from society. Use that brain. And then I tell people that the best drug treatment for progressive MS is not to get it. So take the drugs earlier in the course of the disease to slow the disease down so that you prevent the cognitive problems. We don't have a way to get them back except to stimulate the brain to get it to work as best as we can.
So I have a question here. If my MRI has not changed in a couple of years, then why are my MS symptoms getting worse?
Yeah, you see, the MRI doesn't tell the whole picture. The MRI tells us if there are new spots that we can see, but it doesn't show us those axons degenerating. That inflammation is what we see on the MRI, and we see that inflammation in the nervous system is being attacked by the immune system. That's the enhanced scan. And then we see some of the scars that are left. That's the unenhanced scan. But then the nerves begin to degenerate and we lose function because those nerves are degenerating. Sometimes we see that, and we talked about that being a black hole, but sometimes we just don't see it so well. Now, we have different quality scanners in terms of how much they see. So the typical scanner may be called a 1.5 or 3 Tesla scanner. But when we stick people into 7 Tesla scanners, and I'm not recommending that because that's really a strong magnet, we see so much more. And then we sometimes see the atrophy that's going on, and we can see that. And sometimes it correlates and sometimes it doesn't. But that's why your disease can get worse when we don't see. We don't see everything that we would like to see.
Great.
We don't see function. We see anatomy.
Okay. Does stem cell replacement work for SPMS?
So stem cell replacement is a way to stabilize the immune system so that it doesn't attack the nervous system. So again, it doesn't actually heal the nervous system. It stabilizes the immune system. So we have to get rid of the old immune system, and then we give the stem cell replacement to replace the old immune system. And so in a person who has progressive MS that's not responding to anything else, that has got maybe some relapses, hopefully some relapses associated with it, or some activity associated with it, stem cell replacement therapy would be something to consider. Not first line, not second line, but third line, if you will.
Great. Thanks so much, Randy. This has been a terrific webinar. I think I can sum it up with one of the comments that I got from the participants. It says, awesome joke slides, which makes tough information.
I hope that people laugh at them. It's sometimes dangerous using comics and slides, but especially when I can't see the audience, but I hope that you appreciate it.
I think it makes the tough topic a little more easy to understand and to hear about.
Thank
so
you.
With that, I'm going to say thank you so very much. Again, it was great information and really informative, and I can tell by the comments that we received during during this webinar that our participants really enjoyed it. So thank you so very much. So I would like to inform you of some additional resources that you may find helpful. On the Can Do MS website, you will find the archive webinars, e-news, and library articles. You can also submit a question to the Ask the Can Do team, which will be answered by our team of MS experts. Many people ask how they can get involved with Can Do MS. You can start a fundraiser. You can buy a loci bracelet. You can find that information on our website. You can do monthly giving. You can give up gifts. There's a big thing on Facebook these days to ask for donations instead of getting gifts for a birthday or something of that nature. So there's lots of ways to get involved with Can Do MS. This is a 4-part webinar series. So the next webinar in our series is Managing Your Emotional and Cognitive Well-Being. It's going to be on next Thursday, June 27th, same time. So I encourage you to listen to that. We're going to have one of our renowned psychologists speaking, Roz Kalb, and she will be presenting that webinar along with a person that's been living with MS. So I encourage you to listen to that webinar as well. I would like to thank our partner, Novartis, for partnering with us on this webinar. And with that, Randy, thank you so very much. It's been a pleasure working with you, and I'm looking forward to working with you again in the future.
Thank you.
And to all the participants out there for joining us on tonight's webinar, thank you, and have a wonderful evening.